Welcome to Modern Management of the Older Adult, brought to you by the Institute of Clinical Excellence.
Hello, everybody, and welcome to the PT on Ice Daily Show. My name is Christina Previtt. I am one of the lead faculty within our geriatric and pelvic health divisions, and happy 2024. So I'm really excited because I have been seeing these ins and outs of 2024 all over social media, and I thought they were so fun. And therefore, I wanted to try and do the same thing for geriatric practice. I think it would be so fun. So in today's episode, I'm going to be doing 4 ins and 4 outs for 2024 for geriatric practice. So the first, we're going to start with the ins. And the first one that, if you've been following MMA for any amount of time, is we are going to put high intensity everywhere. And we recognize that high intensity is relative, but we have actually updated our content in the last year to just reflect that we cannot ignore intensity anymore. And that doesn't say that we're going to ignore the accumulated effects of low to moderate intensity exercise. That's absolutely not it. It's that we cannot be afraid of high intensity exercise anymore when we have overwhelming evidence across all life stages and across a variety of different chronic conditions. So when we have octogenarians and individuals with lung cancer and individuals who have had a stroke who are successfully able to participate in high intensity endurance training or aerobic training, we can't ignore it anymore. It's just the evidence is just too strong. And so that is going to be our in, is to push every single day to do something a little bit higher intensity than we previously would and play around with intensity as a variable. That's number 1. High intensity everything. Number 2 is that we need to get objective measures that matter. When we take MMOA live, we always look around the room before we start our outcome measures lab, and we try and make outcome measures fun, I promise. I think it's fun anyway. We ask individuals, how many people are having a goal for their geriatric patients that they need to get objectively stronger? And everybody puts up their hands, right? If your older adult can't get out of a chair without using their hands, their leg strength is less than their body weight, which is a dangerous place for them to be, because what happens if they break their wrist? And so that is almost everybody says, yes, this is what I want them to do. When we ask, how many people take an objective measure of strength so that they know that they're prescribing in the right intensity zones, that is usually a lot less. That's a lot less people putting up their hands. And I get it. We think that we have to 1 rep max deadlift with somebody, and that seems absolutely ridiculous for some of our patients who are maybe seated a lot of the time or have a lot of frailty on board. But that's not the case. That's not the way that we need to do, or we need to always think about objective intensity. We have different ways. And so our in for 2024, number 2, is that objective measures for function matter. And we are not going to know if we're hitting the right spot. There's always this Goldilocks equation, right? I've had people mad at me because I've been a little bit too hot on the intensity, but I've also left a lot on the table from being a little bit too cold. So we have to be able to objectively measure where we need to be, and we need to know what we can do in order to hit those targets. So that's number 2. Number 3 is that we need to start prioritizing a fitness-forward approach to geriatric care. And I know, I would probably say that the geriatric space, with so much being involved in balance, falls prevention, we're not as manual therapy focused. We always joke at ICE that which ones are our Geri crew, because our hands are just not nearly as good as some of our orthopedic outpatient therapists. But there's this idea when we start talking about kettlebells and heavy bands and barbells that fitness forward approach in geriatric care is expensive. And our MMLA crew, we have to just laugh. We laugh and laugh and laugh, because if you look at the cost of a new step, our clinics are not hesitating to buy a $10,000 piece of cardio equipment, but do not want to put in the $1,000 in order for them to be able to get some true measurable objective strength training equipment And Alan tells me, because he's a guru in this stuff, that you can get a lot of that reimbursed through a tax credit. So it is not as expensive as you think, and it doesn't have to be as in-depth as we are thinking when it comes to buying fitness forward equipment. And for our home healthers or those that are traveling, having a heavy rogue band and having 1 or 2 kettlebells in your car is not a huge investment. And it's absolutely something that we can do in order for us to take a fitness forward approach to rehab. So we have 1, high intensity everything, 2, objective measures that matter, that give us information, and 3 is just prioritizing that fitness forward approach. And then number 4, I have to put my Geri pelvic hat on, is that we're going to start removing some of these barriers for women who are postmenopausal to access HRT. There is a big push right now because we see, for example, that topical estrogens can significantly reduce rates of urinary tract infections. Urinary tract infections are absolutely devastating for some of our older adults. And there is a lot of fear. I'm pushing against it every single day in the clinic when I'm working with someone postmenopausal and I bring up estrogen and they say, I talked to my doctor and they said it's dangerous. It's going to give me cancer. And they're not prescribing it. And that is just so behind the times. And that is not where we want to be. So in 2023, we're going to get rid of it. 2024, we're going to be advocates for it. And we're going to have our own knowledge to be able to give our clients up-to-date information about something that can significantly impact their health. I was just reading a cross-sectional survey on menopausal women who were active, and it showed that 68% of them, as they went through the menopausal transition, had an increase in joints, aches, and pains, which means that we're missing something oftentimes in our assessments if we're not trying to take into account estrogen status with how they're presenting in the clinic. So there are our 4 ins: high intensity everything, objective measures that matter, a fitness forward approach, and it isn't that expensive, and using HRT for menopausal women who may be eligible for it. So let's talk about our outs. What are we going to kick out in 2024? Number 1 is we are going to kick out these dismissal of complaints based on age. We are going to kick them to the curb. Almost every condition in our medical system has age as a risk factor. The longer we are on this earth, the more wrinkles we have on our insides, we have on our vessels, we have on our organs. Yes, it is an increased risk for orthopedic musculoskeletal pain, for different signs and symptoms of functions at different organ systems. Yes. But saying that it's because you are such age, or that you should not have the expectations to feel healthy and vibrant at 70 because you're 70, that is not okay. We are going to stop dismissing complaints. Stop saying things as physios like, of course you have bone on bone arthritis, you're going to have pain in your knee, or you're over the age of 60, pain is never going to be completely gone. You're never going to be pain free again. Things that I've heard from rehab clinicians in my area. We need to stop dismissing complaints. The second thing is elder speak. We're going to kick elder speak to the curb. Oh, I have a 99-year-old. She's so cute. She was a surgeon. She has raised 10 children and has 25 grandchildren and is still a really active part of her family. I hear this on our courses all the time. Oh, I have the cutest 75-year-old. It is meant well, but it is dismissing or infantilizing our older adults that deserve our respect and reverence. And so we are going to adamantly hold that line. And kind of a 1 or 2B to this is we're going to really focus on using patient first language. So many times when we ask, like, tell me who you're going to work with to, to implement some of these things from MMOA on Monday, we say, I have a stroke that is 75. Instead of saying, I have a person who had a stroke who is 75. And it can completely dehumanize them. And we do it for quickness of communication often, but it is definitely something that we need to be better at in order to allow individuals to not have their disease central to their well-being and their identifiers as a person, right? We see this all the time, that individuals start to become their diseases. And if we speak like that, then it becomes so much easier for that to happen. right? We do not want to say you are your stroke. You are a person who is hopefully going to live a very high quality, multidimensional life with impairments that you did not have before, but you are not your stroke. So I kind of put that as an elder speak B. Okay. So the first thing we're going to make sure we kick out is dismissing complaints based on age. The second thing is we're going to watch our own communication. We're going to kick out elder speak. We're going to kick out this patient first language, or we're going to use this patient first language. We're going to kick out identifying individuals as a shoulder or a knee, or I have a total joint replacement. Got 3 knees and a hip on my schedule. We're going to kick all that language out because it starts with the way that we communicate in our minds and with our colleagues, and then it trickles into the way that we communicate with our patients. The third thing, this might be a little bit of a lofty goal, but I'm going to say it anyway. We're going to start removing blanket contraindications, right? If you've kind of been around our crew, you know that the bend, lift, twist restrictions after things like lumbar surgery, people go to the bathroom the first day, they're bending right away. They just have to be taught how to bend, or something. We know that our hip precautions don't really do anything. And we have all seen that patient that comes in 10 years later after getting a stent done and says, well, I can't lift more than 20 pounds. I had heart surgery in 2014. And we're like, whoa. What we talking about here? We need to DC those recommendations. So what we're starting to see over and over again is that blanket recommendations are kind of done based on theory of tissue healing. But we know as rehab clinicians that they all respond to stress, right? Our body needs to gradually reintroduce stress across a graft, across a surgical scar, across an injury. And that needs to be done in a nuanced, individualized approach. And these blanket recommendations oftentimes do not really help. And what they do is create a lot of kinesiophobia. And oftentimes, because of the way that our medical systems are set up, where we don't have appropriate or adequate follow-up, because we're just so overrun with a lot of different medical professions, they don't get discharged. And so we want to try and be really mindful of that. All right, elder speak, A and B. Dismissing complaints, blanket contraindications, and then the last one, and I'm going to end here, is that we are going to avoid taking a siloed approach to our rehab. So often, PTs are not tapping the shoulders of our OTs, our speech language pathologists, our social workers, our nurse practitioners, our pharmacists, and we think that we need to know all the answers. It is funny, the more education that I get, the more I realize how much I do not know. Every time we are doing a course, I get somebody teach me something new. And we don't need to. We don't need to know everything because we have our colleagues, we have our friends. Our healthcare system is meant to be a multidisciplinary collaborative process. And I know you all are looking at me being like, well, it's got to go both ways. And I totally agree, especially with our physician spaces. And that is something that I'm really passionate about advocating for as well, is letting our physicians as well kind of pass the baton and say, I don't have the space, I don't have the knowledge, but this person does. And so what I want to see get kicked out in 2024 is this idea that we are our own island, because it just makes our patients feel so alone or so unheard, because the communication doesn't go back and forth. In our medical professions, we're starting to become so hyper specialized that sometimes we only look at the tree and we don't see the forest. This is where our PTs, OTs, rehab clinicians, we do a good job of zooming out, but sometimes we put ourselves in these silos too. I'm not a pelvic floor PT, so I'm not going to talk about your pelvic floor, despite the fact that the reason why you're not exercising with me is because you're peeing every single time. I'm not a vestibular specialist, so you're going to tell me that you're dizzy, but that's not in my wheelhouse, so I'm not going to talk about it, even though it's the biggest barrier to you exercising, right? These are all things that we silo ourselves within our profession, and then we don't often tap on or even look for other clinicians in our area that could be helping our patients. And so we want to take this siloed approach, kick it out, and kind of an in is that we're going to be really try and lean on relationships with our colleagues. And it's hard in a really busy clinic. I get it, but we absolutely have a role to play, and we want to lean on them so that we know what they are capable of. And so we want to even know their scope of practice. So we have so much work to do. So looping this around, what are our ins? High intensity everything, objective measures that matter, a fitness forward approach, and using HRT for menopausal females. What are our outs? We're not going to dismiss complaints because of age and just say, well, you're 80 years old. Nope. We are not going to communicate with elder speak or avoid patient first language. We are going to maybe hopefully get rid of some of these blanket contraindications, take a very gradual approach, and then we are going to kick out this siloed approach to rehab. All right, if you are looking to catch MMOA, our level 1 and level 2 courses, level 1 starts January 10th, formerly known as Essential Foundations. Our level 2 starts January 11th. If you are trying to see us on the road, our first courses back start the 13th, 14th. So we are in Maryville, Ohio, and we are in Santa Rosa, California, the 13th, 14th. And then the 20th to the 21st, we are in Clearwater, Florida, or you can catch me in Greenville, South Carolina. So hopefully we will see you on the road sometime this year, or we'll see you in our courses. We have some big, exciting changes that are coming around the ICE pipeline. So stay tuned. Have a great day, everyone, and happy 2024.
Thank you for listening to the MMOA podcast. If you found this helpful, please share with someone that could benefit. And if you're looking for more practical content to help you better serve older adults, head over to www.mmoa.online, where you can learn more about our free resources, our community, continuing education courses, and our certification. Once again, that's www.mmoa.online. Thanks for listening.